Now we move to severe preeclampsia. What happened to moderate preeclampsia? There is no moderate preeclampsia. It progresses from mild to severe. Mild is conservative management. Severe is going to be managed aggressively. And look at the difference in this case. 21-year-old gravida 1, 32 weeks gestation, confirmed by first trimestral ultrasound, same as the previous one. But look at all of the evidences of severe preeclampsia. For 24 hours, she's had severe occipital headache. What part of the brain is hypoperfused most commonly with severe preeclampsia? It's going to be the posterior lobe, the occipital lobe. And that leads to then the visual changes. She's had mid-epigastric pain, not relieved by acetaminophen. What's a mid-epigastric pain? Swelling of Gleason's capsule of the liver. She sees light flashes and spots. Is your epinephrine level rising? Mine is, just from reading the case. She's gained 10 pounds in 2 weeks. Her blood pressure is 165/115. What is the upper limits of blood pressure in mild preeclampsia? Up to 160/110. Greater than that, it becomes severe preeclampsia. Now, I should say that in the past, preeclampsia has been identified as a triad: hypertension, proteinuria, and edema. The edema is no longer used for diagnosis of either mild or severe preeclampsia. And the reason is because you can have those without edema. You can have edema without preeclampsia. She has 3+ pedal edema. Her fingers are swollen, and I don't ignore that, but that is not necessary to make the diagnosis. Her fundal height is 29 centimeters. Now she's 32 weeks. Is this appropriate? Well, it's a little small, but it's within the normal range of ±2 to 3 centimeters. Fetal heart tones are regular at 145 beats a minute, but notice her urine dipstick is 4+ protein. Headache, epigastric pain, light flashes, severe elevation of blood pressure, and 4+ protein in the urine. Okay, let's just review. What are the blood pressure criteria for severe preeclampsia? 160/110 or greater. What are the proteinuria criteria? 5 grams or more. So mild preeclampsia, 300 milligrams up to 5 grams. Severe preeclampsia, 5 grams or more. Symptoms, either the headache or epigastric pain or visual changes. Now, what's the most common cause of headache in pregnancy? Muscle contraction headache. That's not going to be an indication for delivery. This is a new headache, which is never had before. What's the most common cause of epigastric pain in pregnancy? Reflux esophagitis. We're not going to deliver a premature baby because of reflux esophagitis, but this is a new pain which doesn't respond to antacids. Visual changes. I had a patient once who was at 30 weeks gestation. She woke up in the morning. She couldn't see. She was blind. Her sister came and said, "You got to go see the doctor." "Yeah, but I got to get my hair done up." So her sister got her hair done up, made her put on her makeup. She comes to the emergency department. Who was the first consultant that was called? Ophthalmologist. Ophthalmologist looks in her eye, says, "I don't see any problem there." Took her blood pressure, 210/140. Urine dipstick, 4+ protein. What has she got? She's got severe preeclampsia with nothing wrong with her eyes. This was a central problem in her occipital cortex. We went ahead and delivered her, and within 48 hours, her vision returned. Symptoms. Laboratory tests for severe preeclampsia. If you have evidence of DIC, decreased platelets, decreased fibrinogen, increased fibrin split products, prolonged PT, PTT, that would be evidence of severe preeclampsia. Even if her hypertension is only mild, even if the proteinuria is even mild, if she's got any of these single ones, headache, epigastric pain, visual changes, DIC, elevated liver enzymes, ALT, AST, 5-gamma-GT, and so on, and pulmonary edema, oliguria, cyanosis. So even mild hypertension, mild proteinuria in the presence of any one of these which reflects severe end organ involvement. That is severe preeclampsia. This slide shows the evidence of DIC on a peripheral smear, and you can see the schistocyte, the helmet cell, the fragmented red cell. Risk factors for severe preeclampsia are basically the same as mild preeclampsia, particularly patients who have small vessel disease, systemic lupus, type 1 diabetes, chronic hypertension. Those would be all candidates for severe preeclampsia. Most cases of severe preeclampsia are managed aggressively. Aggressive management, not conservative. That means we give intravenous mag sulfate to prevent convulsions, and we want to continue that for 24 hours postpartum. We want to lower the blood pressure. How far do we want to lower the blood pressure? Remember, in the physiology of pregnancy, the uterus is low on priorities. If push comes to shove, the woman is first going to send the blood to her brain, to her heart, to her kidneys. If anything is left over, the uterus will get it. So we don't want to lower the blood pressure down to normal levels. We want to bring the diastolic between 90 to 100, and we will use hydralazine or labetalol to do that. And then end the pregnancy, induce labor. If mom and fetus are stable, if they're unstable, then of course a cesarean. But not necessarily do we need to do a cesarean. So aggressive management with severe preeclampsia. There are few patients who you might manage conservatively. And these are patients who have no severe end organ effects. They have no headache, no epigastric pain, no visual changes, no DIC, no elevated liver enzymes, no oliguria, no pulmonary edema, no cyanosis. If they're between 26 and 34 weeks, we can lower the blood pressure below 160 over 110. We can put the patient in the ICU, monitor her closely, give her betamethasone to mature the fetal lungs, and continuous IV mag sulfate. If she's less than 26 weeks, there is no evidence of benefit. If she's over 34 weeks, there's no evidence of benefit. And the whole purpose here is to try to get more time for the baby. But remember, there has to be no evidence of severe end organ effects. And that is the end of severe preeclampsia. Remember, there's no moderate preeclampsia. If it's more than mild, it becomes severe.